Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Today we are from Group 4 or Group 3. We present about Hepatobiliary system for I-Pocus course. So let's go. So these are our table of contents. So we'll discuss about history, cholecystitis, indication, guide to HSPS, ultrasound, interpreting imaging, and journals. So without wasting any time, let's go one by one. So first of all, we're talking about the patient history. For the patient has or HOPI, or we're talking as the history of visiting illness. So patient identification, the name will be the Mr. Nobody for confidential purposes. So he is a male, male 39 years old, is a sales businessman and live in Kota Baru, Kelantan. So he was on the third day of admission. And the chief complaint patient was presented to the exit of emergency department of HSM with complaint of sudden right-sided abdominal pain 3 days before admission. So 3 days before admission, patient had sudden right abdominal pain, and this pain can be described in so-called pneumonic. So for the start, it was in the right abdomen. And for the onset, 3 days before admission, character, it was sharp in nature. Radiation, there's no radiation whatsoever. And for the associated symptoms, so there's actually a multiple episodes of bilious vomiting after eating. And the volume of the vomiting will be around 2 cups for each episode. And timing will be continuous pain. And for the excessive factors, no specific factors have been recorded for the patient. And for the severity, is moderate, it's about 7 out of 10 score. So on the day of the admission, patient went to the red zone of emergency department due to worsening right abdominal pain. So the vital signs at emergency department were within normal range, and he did abdominal ultrasound and was given painkiller, and he was then admitted to 2 in 10 after that. Otherwise, there's no patient was febrile, no ULTI or UTI symptoms, and no loose stools. So from this HOPI, we can actually highlight certain differential diagnosis relevant with the patient's complaint. So we have 4 differential diagnoses. First, which will be the acute cholecystitis. Second will be the acute appendicitis. Third will be acute gastritis, and the fourth will be renal stone. So each have their own positive and negative relevance. And for the differential diagnosis, after we did the physical examination, so the summary, the general is normal. But however, during the abdominal examination, we can determine that patient actually had the tenderness at the right upper quadrant region during palpation, and actually the Murphy signs which suggests acute cholecystitis. However, Murphy signs was negative, which actually can exclude the acute appendicitis. However, during the cardiovascular endoscopy examination, there's no significant findings, and that's why we come up with differential diagnosis as acute cholecystitis. So, what is acute cholecystitis? It can be defined as the inflammation of gallbladder to the obstructed cystic duct due to certain factors can be obstructive, inflammatory, and vascular. So this is called the high gallbladder glandular secretion, which causes the gallbladder distension, which eventually will compromise the vascular supply to the gallbladder itself. So the types, it can be divided into 2 types. First is acute calculous cholecystitis due to the stone, and accounts for 90% of the cases. Second will be the acute acalculous cholecystitis, which is non stone, and it's due to the inflammation and ischemia of the gallbladder, which accounts for 10% only of the cases. So investigation can do the full blood count to detect for any high white blood count for the infection. We can do the amylase for high amylase, liver function test to detect for any high alkaline phosphatase, and the ultrasound, which actually will be estimated further by the next presenter to detect for any gallbladder stone, contracted gallbladder, cholestatic fluid, thickened gallbladder wall, and sonographic Murphy sign positive. As this case, we want to exclude any complications due to acute cholecystitis. Can be the perforation, gangrene, and peritonitis, gallstone, ileus, and mucosid. For the management, we can do the non-surgical management. We actually include the painkiller and antibiotic. And for the surgical management, we can do the cholecystectomy, be it open or endoscopy.
Alright, so we will talking about indication for POCUS. So, indication for POCUS. There is 5 indication. The first one is right hypochondriac region. The second one is happy gastric pain. The third one is abnormal blood investigation. And the third one is jaundice. And lastly is sepsis. So, why we decided to do hepatobiliary system ultrasound? Why? Okay. The first one, because our patient have complained of sudden right-sided abdominal pain 3 days prior to admission. And then, on examination, there is presence of tenderness of right upper quadrant region. So, this is just like what I said before, is indication for the pockets. So, because there is presence of right hypochondriac pain. So, the same goes on to our patient. And then, the Murphy sign was positive and the Rough sign was negative. Okay, when Murphy sign was positive, there was indicative for acute cholecystitis. So, that's why we do POCUS for hepatobiliary system, because for currently our differential diagnosis was acute cholecystitis. Alright.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So I will continue in the presentation. So for this part is how to guide to hepatobiliary ultrasound. I'll be present on the first part and Sarah will be presenting on the second part. So on this part, on components in biliary POCUS, there are several main components that we need to evaluate. There are 5 main components that we need to evaluate. The first one would be the gallstones, gallbladder wall thickening, pericholecystic fluid, common bile duct CBD distension, and sonographic Murphy sign. And this, if this finding is positive for maximal tenderness in right upper quadrant, is identified while the gallbladder is visualized on the ultrasound. So technically, in order for us, the most important part of POCUS for hepatobiliary is this 5 particular thing for us to detect when we are doing POCUS point of care ultrasound. So the technique, the probe selection. So technically, we have two most preferred probe, which is the curvilinear and also the face array, which is the cardiac probe. And the patient position, the patient need to be in supine position or upright sitting position if the patient is a difficult patient. There are 3 main principal approach, which is the first one is the subcostal sweep, the second one is the X-7, and lastly flattening the probe. So these are the 3 most important principal approach that we need to know. So moving to the first one, the subcostal sweep. Firstly, you need to place the probe over xiphoid process in a longitudinal orientation, and it must indicate it towards the patient head. Sweep the probe along the subcostal margin, and the image may improve by asking the patient to inhale deeply so that you can visualize much more better the POCUS on the screen. So next is the X-7, the X- sweep. So how do you do this? Is technically by placing the probe in the nearest intercostal space, and then the gallbladder should be just posterior to the liver, directly beneath the probe. And the approach is used to visualize how gallbladder through an intercostal window, and the gallbladder is not if the gallbladder is not identified, continue to move the probe laterally while fanning through the liver parenchyma until you can identify the structure of the gallbladder. But for me, you need to know first what is the normal picture or image of the gallbladder that I'll be explaining after this. Then lastly, flattening the probe. So you need to place the probe subcostally and the probe marker to the patient's right and the probe aim towards the patient's right shoulder, and fan anterior to posterior until you identify the gallbladder. So talking about identifying the gallbladder, this is the normal image of the gallbladder, which there is no pathological changes. This is a normal gallbladder. You can see there is the common bile duct, the hepatic artery, the portal vein, and you can see the gallbladder there. And this one too, you can see that when you are viewing based on the long axis, you can see that you could also visualize the liver and the other part, the hepatic duct and all, and also the gallbladder. But the most one of the key takeaways that you need to know that the gallbladder shape would be a bit different during fasting and also postprandial, which is both of it is a normal gallbladder, but it depends on whether do you fast or not. So as you can see, if you are fasting, then the gallbladder would appear anechoic and pear-shaped structure, thin wall, and the gallbladder neck should cross towards the CBD and portal vein. But if postprandial, usually the gallbladder contracted and the thin wall may contract and leads to possible thick appearance. But it is not a pathological changes. It is just a normal physiological gallbladder, but it is a postprandial gallbladder. So this one you can see, this is the imaging of the normal gallbladder, the fasting, and also the postprandial. You can see that both of this is physiological imaging of normal gallbladder. This is just because of the fasting, the bile is still inside, and postprandial is because the bile was excreted out. That's why it looks much more thinner. But both are not pathological, and both are physiological imaging for a normal gallbladder. And lastly, the CBD short agris, one of the most important key takeaways is the Mickey Mouse sign. You can see it's very easy for you to remember this part, which is it consists of portal vein, hepatic artery, and also the CBD. And you can see on the picture when the power flow of droplets added, large vein and hepatic artery can demonstrate the flow. You can see on the picture. And lastly, on my side, this is normal, and also the fasting, also the postprandial gallbladder. Both of these are normal, and this is not a pathological gallbladder. So I think that's all on my part, and Sarah will continue presenting on the other part of the gallbladder. Thank you. Assalamualaikum.
So these are the steps you need to do to scan the gallbladder using ultrasound. For step 1, we need to find the gallbladder. By probe selection, we used curvilinear probe, and then patient position, and then done the 3 principal approach. For step 2, examine the gallbladder by scanning the gallbladder in multiple longitudinal and transverse planes to ensure the exact location. And step 3, assess for the sonographic Murphy signs. We place the ultrasound probe directly over the gallbladder fundus, and then you compress the gallbladder. If patient has pain during inspiration, or if they stop during the inspiration, it means the Murphy signs is positive. Okay, after done, we proceed with the step 4, which we need to find the portal triad. Once the portal vein is visualized, you rotate the probe 90 degrees, and this will usually bring the portal vein, CBD, and the hepatic artery into transverse view, and then you can see the Mickey Mouse sign. Okay, so this is the Mickey Mouse sign, where you can visualize the portal vein, hepatic artery, and common bile duct. Okay, in long view, you can visualize the IVC, portal vein, and also CBD. After that, we need to measure the CBD. The normal diameter of the common bile duct is less than 5 mm, and upper limit of normal size will increase with age. Enlarged CBD and right upper quadrant pain suggests chordocolithiasis. Okay, this diagram show you the example of dilated CBD, where if we measure, it will be more than 5 mm.
Assalamualaikum, doctor and fellow friends. I am Naili. I will present to you our patient's ultrasound finding. So we are looking at the liver now. We can appreciate how its echogenicity is slightly increased with smooth liver margin. Actually, we measured the liver span and it is 16 centimeters, and there's no liver lesion lah. Portal vein is patent and not dilated, measuring 0.9 centimeter, and there was no biliary dilatation. Gallbladder was distended, and we could appreciate multiple echogenic calculi within the gallbladder, measuring about 1.4 centimeter. There was also presence of wall thickening with pericholecystic fluid. Otherwise, visualized pancreas was normal and there was no pancreatic lesion. Visualized spleen is homogeneous with no splenic lesion, and we did not see any free fluid in the visualized upper.
Hi, Assalamualaikum everyone. So my name is Noamira Alia, and I will be presenting the last part of our presentation, which the journals that I have found to be supported the use of I-Pocus in diagnosing the case that we have chosen, which is acute cholecystitis. So the first journal that I found, the title is Prospective Validation of the Bedside Sonography Acute Cholecystitis Score in Emergency Department Patients. So the objective of this journal is acute cholecystitis can be difficult to diagnose in the emergency department. No single finding can rule in or rule out the disease. So the purpose of this study was to prospectively validate the bedside sonography acute cholecystitis SAC score utilizing a combination of only historical symptoms, physical exam signs, and point-of-care ultrasound focus findings for the prediction of the diagnosis of acute cholecystitis in ED patients. So the method for the study was conducted at 2 tertiary referral academic centers in Boston, Massachusetts. So from April 2016 to March 2019, adult patients which are more than 18 years old with suspected acute cholecystitis, they were enrolled via convenience sampling and underwent a physical and a biliary focus in the ED. So, three symptoms and signs, which are postprandial symptoms, right upper quadrant tenderness and Murphy signs, and also two sonographic findings, which are gallbladder wall thickening and the presence of gallstones, were combined to calculate the bedside sonography acute cholecystitis SAC score. Then the final diagnosis of acute cholecystitis was determined from chart review or patient follow-up to 30 days after the initial assessment. In patients who underwent operative intervention, surgical pathology was used to confirm the diagnosis of acute cholecystitis. And sensitivity, specificity, PVV, and NPV of the bedside SAC score were calculated for various cutoff points. So the results from the study, 153 patients were included in the analysis. Using a previously defined cutoff of more than 4, the bedside SAC score had a sensitivity of 88.9% and a specificity of 67.5%. A bedside SAC score of less than 2 had a sensitivity of 100% and specificity of 35%. A bedside SAC score of more than 7 had a sensitivity of 44.4% and specificity of 95.7%. So the conclusion from this study, a bedside prediction score for the diagnosis of acute cholecystitis would have great utility in the ED. The bedside SAC score would be most helpful as a rule out for patients with low bedside SAC score less than 2 or as a rule in for patients with high bedside SAC score more than 7. Prospective validation with a larger study is required. So the second journal for our presentation is the absence of gallstones on point-of-care ultrasound rules out acute cholecystitis. The objective of this journal is to determine whether the finding of gallstones alone on I-Pocus has high sensitivity, high negative predictive value, and low negative likelihood ratio for the exclusion of acute cholecystitis. The methods that were used, they conducted an analysis using data from a prospective cross-sectional single-center study of I-Pocus tests to estimate the test characteristics using a simplified definition of a positive test, which is the presence of gallstones alone. Clinical follow-up and pathology reports were used as the reference standard. Test characteristics were calculated and compared to the standard definition, gallstones plus one secondary findings. So the results from the study done, the overall prevalence of acute cholecystitis was 14% with 23 pathology confirmed cases of 164 included patients. The sensitivity of the simplified definition was 100%, the negative value 100%, and negative likelihood ratio was less than 0.1 compared to a sensitivity of 87% and negative likelihood ratio of 0.16. So the conclusion from this study, simplifying the definition of test findings on I-Pocus to gallstone alone, has excellent sensitivity and negative predictive value for the exclusion of acute cholecystitis. This finding, if broadly validated prospectively, confirms the practice of excluding acute calculous cholecystitis using I-Pocus in emergency department patients. So this is my third and last journal that I have put for our presentation. The title is Evaluating the Diagnostic Accuracy of Point-of-Care Ultrasound for Cholelithiasis and Cholecystitis in a Canadian Emergency Department. So the objective of this journal, As we all know, cholelithiasis and cholecystitis are common conditions that frequently require patients to come to the emergency department and undergo diagnostic imaging. The purpose of this study was to evaluate the test characteristics of emergency physician perform point-of-care ultrasound to diagnose cholelithiasis and cholecystitis in a Canadian ED. So the methods that were used, a health records review was performed on all ED patients more than 70 years of age, for whom I-Pocus was performed to diagnose cholelithiasis and cholecystitis in a Canadian academic ED over a 5-year period. So the sensitivity, specificity, predictive values, and likelihood ratios were calculated. And the gold standard used for diagnosis was pathology, laparoscopy, radiology performed comprehensive ultrasonography, followed by computed tomography scans. So the results, a total of 577 patients were included in the study. The sensitivity and specificity of I-Pocus to diagnose cholelithiasis was 95.2% and 93.1%. The positive and negative likelihood ratio for I-Pocus to diagnose cholelithiasis were found to be 14 and 0.05. The negative predictive value was 97.6%. The sensitivity and specificity of I-Pocus to diagnose cholecystitis was 67.1%, and the positive and negative likelihood ratios for I-Pocus to diagnose cholecystitis were found to be 28 and 0.34. The negative predictive value was 95.6%. Therefore, the conclusion from this study, I-Pocus is reliable for the diagnosis of cholelithiasis and for ruling in cholecystitis. In cases where I-Pocus is negative or indeterminate for cholecystitis, further imaging should be obtained as clinical suspicious warrants. Okay, so this is the list of the references on the 3 journals that I have just presented earlier. So I guess that's the end of our group's presentation. Thank you very much.